Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Let's do this. Hello, Dr. Kevin Boyd. Thank you so much for being here.
So glad to be here, Nicole.
Well, I'm just so happy to have you here. I know you are such a busy guy, and it's just an honor to have you here. You're the man, the myth, and the legend, Dr. Kevin Boyd.
Oh my, that's going to be hard to live up to.
No pressure. But
Yeah.
Honestly, Dr. Boyd, like one of the things I really treasure and value about you is how you're just so curious and open and always continuing to learn and to teach, and you're not judgmental. I mean, I feel like you're always open to new ideas and learning from other people, and you're always have a desire to make positive change for children and adults as well in the airway realm. And you're just really supportive. So I really want to thank you for all you do. And that as an extra side of if I have an idea or a question, you always are open to talking, to helping further my education. So I really want to thank you for that.
Well, you bring up the word judgmental, and that's a constant battle because I constantly have to remind myself if I get frustrated with colleagues that I want to collaborate, and they're like, "Hey, you're a dentist, just be a dentist and fill cavities." But they may not say that, but they're thinking it, and I'm like, yes, I am a dentist and I just do dentistry, but the airway is now considered a compound according to the American Dental Association, right? So when people aren't open or receptive, my first temptation is to be judgmental. And then I remember where I was 15 years ago. 15 years that I spent half of my career being totally in the dark about this. So I have to remember where I come from. I didn't come out of dental school or even my pediatric fellowship at Iowa knowing this stuff. So yeah, we have to be open and non-judgmental. It's the only way. So.
And I feel like you always portray that and remind me of that. And if people pose a question like, oh, the pediatrician doesn't know about this and don't talk to the pediatrician or the ENTs, you always rephrase it as they just haven't been educated yet. That understanding aspect versus us being angry. So I really appreciate that about you.
Oh,
And I'm
good.
sure
I'm glad. Yeah, I'm glad you feel that way because I've only come upon that way of thinking, I don't know, in the last maybe year or two. And so, yeah, that's edifying to me that you said that.
It's really helpful for us all to just if we think along those lines as people who don't understand where we're coming from, just don't have that education yet, it helps us continue to spread the knowledge versus getting angry that people aren't seeing what we see. Because for most of us, it's so obvious that, like that whole saying, once you see it, you can't unsee it. But when we come across like the pediatrician or even other dentists or orthodontists who aren't seeing what we see, sometimes our temptation is to get really angry, but to help find a way where we can communicate with them and understand its different perspectives, different experiences is really helpful in a non-judgmental way. And I want to go over your bio. Again, I'm sure everybody knows who you are, Dr. Boyd, but I want to really capture your background and all your training. And I have a lot of really good questions for you also. So Dr. Kevin Boyd is a board certified pediatric dentist practicing in Chicago. He is also an attending instructor in the Pediatric Dentistry Residency Training Program at Lurie Children's Hospital, where he additionally serves as a dental consultant to the Sleep Medicine Service. Prior to completing his dental degree from Loyola University Chicago College of Dental Surgery in 1986, Dr. Boyd obtained an advanced degree in human nutrition and dietetics from Michigan State University, where his research interests had been centered upon unhealthy diet, eating, dental caries, obesity, and diabetes. Dr. Boyd attended the University of Iowa for his postgraduate residency training, where he received a certificate in pediatric dentistry in 1988. Dr. Boyd has served on the teaching faculties of the University of Illinois College of Dentistry, the University of Michigan's College of Dentistry, the University of Chicago Hospitals and Clinics, Rush Presbyterian St. Luke's Medical Center, and Michael Reese Hospital as an attending clinical instructor in pediatric dentistry. Dr. Boyd is currently are you still completing prerequisite coursework in biological anthropology at Northern Illinois University?
Well, I'm never going to get that done because I got partially to a bachelor's degree in my 50s in anthropology. And then I was invited to be a visiting consulting scholar at Penn. And okay, I'll just do this now. So I'm still with Mariana Evans. We're both visiting scholars, and we're not doing too much since the pandemic, but it's been an amazing ride.
That's amazing. That's what I talk about.
Yeah.
Your curiosity to continue to learn about all this and research, investigate history is so amazing. So you have that whole dental, anthropological, nutrition education as well. And your clinical focus is centered around prevention of oral and systemic diseases through promotion of healthy sleep, breathing, and eating. His primary research interest is in the area of infant and early childhood feeding practices and how they impact growth and development of the craniofacial respiratory complex and associated neurological development. And that's amazing that you and Mariana Evans worked doing research at UPenn Archaeology Department and Anthropology Department. And you are recently appointed as adjunct professor to the Department of Anthropology at the University of Arkansas. Is that correct?
Yeah, that was also before the pandemic, and I was mentoring one of the PhD students, Catherine Lewis, I'm sorry, not Catherine, Cheyenne Lewis. And the pandemic kind of interrupted all that. And so I haven't really been going back to Arkansas very much, but we were taking really pre-industrial skulls and we were getting cone beams in Rick Robley's office, which is near the University of Arkansas Department of Anthropology. And it's in a building called the Old Main. And Dr. Jerry Rose, who's emeritus chairman of anthropology at Arkansas, has stepped down, but he's still a good friend. And I try to bother him a little bit now and then to get some answers because he is a real anthropologist. I'm a wannabe, but really enjoying it and enjoying what I know and trying to learn more.
So neat, so fascinating to want to know like the history. Where did this all come from? Why is the human face so messed up? So I want to step back and ask
Yeah.
you, like, how did you even become interested in being a pediatric dentist and then specializing in early intervention and airway components? Like, was there an aha moment for you in terms of that? So let's hear about like how you initially got into this.
Well, I knew I wanted to be a pediatric dentist before at my interview. That's when they were still interviewing at Loyola back in the early 80s. I said at my interview, they said, "Why are you here? Why do you want to go to dental school?" And I said, "Because it's necessary for me to do a residency in pediatric dentistry." So I knew I was a little bit older. I'd already done a master's degree. I had focused on child and infant nutrition when I did my nutrition degree at Michigan State. And I grew up in a dental family. My dad was a dentist. Now we call him a primary care general dentist, but back then it was just a GP. And he saw a lot of kids, and a lot of my friends just were like looked up to him, and I just thought it was so cool. And we'd go places, and hi, Dr. Boyd, and I just like had a really good feeling. I wanted to be like my dad, right? So that's how it started, and then ended up doing the fellowship at Iowa, and that opened up a whole new world to me. And that was before I was just filling cavities and trying to prevent them. I was really pushing for preventing cavities, and who's got time for that? We're too busy putting out sugar fires, get back to work. So there wasn't a whole lot of prevention going on other than providing sealants and doing professional cleanings, all those billable procedures. Doing diet counseling doesn't pay anything, even though there's an ADA insurance code for it. I've never been paid for it once, and I've been doing it on every patient for 30 years. So I don't know. It's just endemic. It's how people make a living, putting out sugar fires. But a lot of people are. I work with Lauren Ballinger and Loria Nahadas and Carla Damon. These are all pediatric dentists that really aren't making their whole living doing restorative dentistry and doing more for prevention and focusing more on helping kids sleep and breathe better. It is an oral health procedure and you can make a living at it, but it takes a while.
Yeah. Yeah. And what got you interested in the airway aspect of
I would say luck. Back in the days when Lurie Children's Hospital was called Children's Memorial Hospital, we had our faculty required to attend meetings in an old building. And I happened to come in late and sit in the only open seat, which was next to this handsome white-haired gentleman in a gray lab coat like mine. And we looked at each other. He saw my name, I saw his name, and we both identified each other. Oh, you're Steve Sheldon. Oh, you're Kevin Boyd. We had heard of each other within the realm of sleep and breathing. And he knew I was treating little kids with expansion, and I was doing Bill Hang's orthotropics course, and he knew who Bill Hang was. And he said, "Come on, have you had lunch yet? Let's go over to my office. I want to talk to you." And spent maybe 2 hours there. And he recruited me to become a consultant in my same hospital where he was on staff. And that was 15 years ago. And we've since written book chapters together and lectured together. And he's retired now, but we still talk and see each other. And he still says to me always, "So what, Kevin?" If I come to him with an idea, his first question is, "So what? Tell me why." And he's
yeah,
always loved to do that with me. And we get into the best conversations. And I don't know,
I bet
there's
you
our
have
history.
amazing conversations with
Yeah.
Sheldon.
Yeah.
Um, so okay, so 15 years ago, you were doing early intervention for children. When did that start where you thought beyond practicing just dentistry, but working on dental facial development, or how would you describe it? And when did you start working with children so young to help with craniofacial growth?
Well, one of the reasons I went to Iowa, and this was before the match, when you want to do a residency, you rate places you want to go and they rate you. And then, well, they didn't have that then. And I got accepted. At the time, University of Iowa Hospitals and Clinics was the largest teaching institution in healthcare in the world. And they had the best pediatric dentistry residency, hands down. I mean, everyone claims it, but I knew Iowa was where I wanted to be. So I was very fortunate to the then director, Jimmy Pinkham, who had a PhD in education, and he selected me right there, then and there. And it just happened. One of the reasons I wanted to go there was because Dr. Clemens Full and Art Nowak, they taught the residents. They were hospital and clinical directors in early orthodontics for special needs kids. And really, any kid under 6 that needs orthodontics, they're special needs, whether they have disabilities or not. They need special care and attention, behavior guidance, we call it. Well, Iowa was just top drawer in that. So I was doing really aggressive early orthodontics, meaning before 9 years old. That was considered being early treatment. I call a 9-year-old a geriatric patient now. We're starting them as young as 2, 3, and 4. 3 to 5 is where is my focus, where I want to be. And that's where we can make the biggest difference because we know hypoplastic malocclusion, meaning the jaws are too far back and too narrow, that will not self-correct. When you discover it between 2 and 5 years old, it will always become more complex. And that was taught to us at Iowa, but we really weren't intervening till between 7 and 9, which was 2 or 3 years before the orthodontists were. So that's where I learned to do it. And then I got into private practice where I was still doing restorative, doing pulpotomies and operating room cases with kids with bad cavities. But I was doing early treatment. And now and then a parent would come to me, "Oh my gosh, when you fixed his crossbite with expansion, he stopped wetting his bed." And I would say, "Okay, if you say so." I just didn't see a connection. And then later on, because of Dr. Sheldon, and a guy named John Kelly, who's a primary care general dentist in Chicago, used to be the team dentist for the New Orleans Saints. He taught me a lot about this, and he had done Bill Hang's orthotropics course. So John and I and Steve Sheldon, we did a lot of work together, and that's how it evolved into what it is now. John doesn't treat kids anymore. He treats mostly adults, but I'm highly focused on children, and not just with the malocclusion, but like Linda D'Onofrio, who you talked about with Jerry Simmons in your interview this morning. She's the one who made the connection between orofacial myofunctional disorders and malocclusion etiology. It's 100% connection. And there's lots of references for this. So I'm so dependent on having a myofunctional therapist to work with me. And I recommend it on every single case.
Yeah, Linda
That's where it's at.
D'Onofrio's article. Yeah, we always talk about that oral dysfunction as a cause of malocclusion. So she lists I believe it's 10 different related factors of oral dysfunction to malocclusion. It's a great article. It just puts it all together, and it's a perfect segue to let's talk what causes malocclusion, Dr. Boyd. What do you think the cause of malocclusion is?
Well, for one thing, because of my anthropology training and curiosity, is that we know at no age, meaning from birth to 50, 60 years old, and everyone says, well, people didn't live past 30. Well, yes, they did. There's 70-year-old people, there's not very many of them that lived 30, 40,000 years ago. Okay, well, they didn't have teeth, and that's usually why they died before, because their teeth are all worn down to nothing. But there was no malocclusion really at any age. And the hypothesis is that if a child had antecedents to myofunctional disorders, meaning that they couldn't breastfeed, they died maybe of an infection or predation, if they had the beginnings of a myofunctional disorder, they wouldn't live long enough to develop a malocclusion. It was necessary to survive childhood and live to the age of reproduction. That's called evolutionary fitness, or the ability to become an ancestor yourself, to pass on your genes. Everybody who made it to the age of reproduction, they had perfect, wide, forward jaws with well-aligned, starting to wear down after weaning. But there was no malocclusion until about 300 or 400 years ago. And that means we go over 300,000 years. That's how old our genome is, and has not gone appreciable change since then. How do you go that long with no malocclusion? And then something called the Enlightenment, the Renaissance, the scientific and industrial revolution, all those things happened within 300 or 400 years. And then all of a sudden we have malocclusion. Is that a coincidence? That means our genome, if you land on the planet with an intact genome, which is 99.9% of people, there's the capacity there. We're hardwired to build a perfect occlusion, but it will not just happen. Kids will get taller from 2, 3, 4 years old, but their malocclusion, the bones of the jaw, the craniofacial respiratory complex, they will not grow to their full potential like long bones do. So that's a real hard thing for people to understand. Jaws need to be stimulated, as they were throughout our Hall of Human History, through nursing and weaning and breathing clean outdoor air through the nose, chewing, masticatory competence, respiratory competence. Those are all things that had to be established from birth, or the kid didn't make it. So that's a hypothesis that we're finding support for.
Wow. It's so profound. So basically, if someone had a myofunctional disorder 300, 400 years ago, where maybe they couldn't breastfeed, like you said, or they couldn't chew well, or had swallowing issues, they wouldn't live long enough to actually develop malocclusion. Is that the theory?
Well, no, that would be way before 300, 400 years.
Yeah.
We can live with
Okay.
anything after industry. That's because we could feed them artificial milk, and you can keep people alive of things that used to kill them. Or when I was a kid with Down syndrome, they weren't expected to get into teenagehood, like in the 60s. And now there's senior citizens that have Down syndrome. So people can be kept alive with things that used to kill them, or at least shorten their lifespan. So in malocclusion, enters in to the human condition along with artificial foods and ultra processed foods and antibiotics, and there's just all kinds of things that allow malocclusion to persist now. And I'm not saying that's a bad thing. I mean, occlusion, but still you can thrive with malocclusion. You can survive and thrive. Thriving can be even better if you don't have associated respiratory and cardiac and poor hearing and neurological deficits that can be associated with malocclusion. But, surviving and thriving, that's what it's all about. And that's what we're all about.
This is interesting. The bones of the craniofacial respiratory complex do not grow to their genetic potential like the long bones of the body.
Precisely. Perfectly said.
Like our legs, our arms will naturally most likely grow to their potential, but the craniofacial bones need muscle stimulation to grow. Is that?
Yeah, well, we can say it like this. I know that they call it somatic growth of the long bones. Now, of course, you need good nutrition, you need sleep, you need exercise, you need sunlight, and that will maximize a child's genomic potential for height that it was conferred by virtue of what I say is the parents that they chose or the luck of their birth, is that mom and dad will give them a genomic potential for height of the long bones. And it would occur maybe to 70 to 80%, I've read, even if a kid isn't fed well and doesn't sleep well and doesn't have good nurture, they still will get the majority of their height potential. The facial bones and connected to the respiratory apparatus, those don't develop that way. They need help. We start out with the potential, but they need stimulation. They need what I call it masticatory competence. And I can show you a stack of 20 articles from mostly the anthropology literature, but certainly dental and medical literature that is informed by anthropological reality, is that masticatory competence is something that entered into the human condition when we broke away from our genus Homo erectus, okay? That was 2 million years ago. They were pre-human or proto-human, but they still had brains they evolved bigger brains starting about 2 million years ago. The first Homo erectus, they're called, they enter into the fossil record about 1.9 million years ago. And their brains then were not that much bigger than chimpanzees, but they continued. They're one of the longest living species, and Neanderthals they were even longer than Neanderthals as long as they lived, is that Homo erectus lived until about 100,000 years ago, maybe 150,000 years ago. Well, we've been around for 300,000 years. So we coexisted with Homo erectus. Well, their brains, when they were living with us, were almost as big as ours were. They were over 1,000 cc's. Ours are between 1,250 and 1,400. Neanderthals were 1,500 cc's. Well, those brains of Homo erectus started to get a lot bigger, and then we evolved away from erectus into us, okay? So I won't give an anthropology lesson here, but brain growth is something that it's been an enlightenment for me, is that as the genus Homo's brains started getting bigger and evolving away from our nearest primate ancestor, which was the chimpanzee some 6 million years ago, their brains were about, 300, 350 cc's. That's our common ancestor with chimpanzees 6 million years ago. But the chimp in the zoo, their brains haven't gotten any bigger in 6 million years. They're about 300, 350 cc's. You've heard of Lucy, the Australopithecus afarensis, who lived 3.2, 3.4 million years ago. Her brain, and they say her, it could have been a male, but her brain was just a little bit bigger than a chimpanzee's. And they weren't quite bipedal. They weren't walking just bipedally. They were still hunched over and they would use their forelimb. But the genus Homo, we were completely bipedal and in large brains and walking on 2 feet. That's what distinguishes us, and the ability to start fire from scratch. Those are three things that really differentiate the later Homo erectus and us, and probably Neanderthals had that ability as well. So told you maybe a whole lot more than you wanted to know.
No, I
But
really love this. It's so fascinating. It's like hard to picture all this. Like, how does
yeah.
this all happen and the change over time? Okay, so then what happens next? Like, how do
Well,
we
one of the things that I said, even going back to the common ancestor with the chimp that you see in the zoo 6 million years ago, if you go all the way from that 6 million years, is that changed into Ardipithecus? That changed into Australopithecus? That changed into genus Homo about 2.5 million years ago? Homo erectus, Homo habilis, supposedly the handyman was before erectus? No, they're saying now that was just a form of erectus. It was early. And then they're Homo ergaster. Well, no, that was also erectus. Okay. And as the brains got bigger, the the jaw muscles got smaller, the teeth got smaller. That's what's left out of the equation. The jaws
okay,
got smaller, the faces got smaller, the guts got shorter because we were eating meat because we had discovered how to start fire and cook meat.
uh-huh,
Before, we used to be opportunistic. We'd wait till there was a fire and get a dead animal that was cooked, or we would scavenge, and then we became obligate cookers with fire. So there's a sequence, and I remember it is that we were opportunistic, and then we became obligate. And in between, those were things where we would scavenge. So I remember OSO. That's how we were with fire. There's evidence of fire molecularly. They can find charcoal, and these were indoor hearth fires maybe a million years ago. But why do we say we must have been able to have it before around 2 million years? How come? Because that's the only way our brains could get bigger and our jaws could get smaller,
wow.
because we could cook it and we didn't have to chew it, and it was excellent nutrition. Before, we would hunt all day long, and then we would chew the rest of the day, and we didn't have extra energy to build a big brain. The gut is an expensive organ. Our guts were able to get smaller, and the brain could now get bigger. This is a hypothesis, the large brain hypothesis, that Leslie Aiello is the anthropologist that first proposed that. And then Richard Wrangham wrote a book called Catching Fire. Everybody should read it. And he came up with the expanding brain from 2 million years ago as evidence that we had mastered fire, that we could cook our meat after we captured it.
This
So,
is so cool. This is like music to my soul. This is so cool. I'm like,
oh,
it's
I'm so
like
glad.
campfire stories. Like, I'm like, wow, I can't even picture this. So as
Yeah.
the brain got larger, which coordinated with the ability to make fire, then we're cooking food, so there's less
Yes.
chewing. So our jaws
Yes.
are not developing to their full potential. So brain's getting bigger, mouths are getting smaller. That's
Very gradually. And
okay.
the teeth were also getting smaller. So there was still no malocclusion ever on
Okay.
any of those species. They all had perfect jaws.
Okay.
Okay. They had wisdom teeth erupted, all of them. And you don't start to see skeletal, hypoplastic, dental malocclusion till about 300 or 400 years ago, and not appreciably till about 200 years ago, when the Industrial Revolution was really in full swing. Women entered into the workforce in textile mills, could not stay at home and nurse and wean, baby led wean into the third year of life, which went on throughout human history. Okay. This is a hypothesis, but it's highly supported. But we need to incorporate tools from the basic life science. We learned biology, chemistry, biochemistry, embryology. We did not learn anthropology and evolutionary biology. That is a basic life science, and it is entered into medicine. And I am with people like you and Gloria and Lauren Ballinger and certainly Mariana Evans. We're trying to bring this into the discipline of dentistry. We need this basic science to understand all this.
It makes sense because if we're going to fix problems, it's good to know where they came from, and that will help
That's
guide
right.
in how to fix them.
100%.
So during the Industrial Revolution, women started working more. There was less breastfeeding. Food became more processed, so there's less chewing.
Yeah.
What else occurred during that time? Maybe
Air,
pollution?
dirty air, pollutant
Yeah.
air. Absolutely. Is that the air got more difficult to breathe because of industrial smoke, and women, they're smaller, kids are smaller. Guess where they can go? Coal mines. These little kids and women were hauling up coal from the coal mines. So I just there are lots of things that go into it. And it's still a hypothesis that's being developed. I mean, Nicole, this is how one of the things you and I first connected on maybe 10 years ago. You've always been fascinated by this, you and your husband. So I've always enjoyed sharing this with you because I know it's falling on fertile ground and you're going to do something with it.
Yeah,
So,
I
yeah,
mean, I just worked with orthodontist who one orthodontist in particular, I remember he told me, he's like, "It's all genetic." And I don't even know, it was great he thought about myofunctional therapy and referred patients, and I think that stopped actually, but he's like, "It's all genetic," and didn't wanna hear about the other aspects, the epigenetic influences. Can you talk about, like, how much of the jaw and facial features are genetic? Like, is there a certain percent, or you know how they say, like, oh, you're born with your dad's teeth in your mom's jaws, and that's why you have malocclusion. How much of that is true, and what percent does the nature or does the nurture play a role?
well, there are genetic predispositions to certain phenotypes. I mean, not every kid that's obstructed is going to develop a really overt, long Abe Lincoln adenoid face. But you know what? It's going to be longer than it would, but there are some genotypes that are resistant to becoming long faced, but they're the ones that are the outliers. If you have a neutral or meso occlusion, or certainly a disto or a dolichofacial facial pattern, it's going to be exacerbated if you're a mouth breather. And that's why they call it an adenoid face. So, but everything is, when parents say to me, how much is this genetic? Well, everything's genetic because we all have genes. Okay. So,
But
one
it's
thing
not
that
all
all well, no, it's not, when they say, oh, it's genetic, what they're meaning is it's genetically predetermined. You got no choice. If you got recessive B, you're going to have blue eyes. Well, you know what? Hardly anything works that way. There's very few diseases that it's one gene, one disease, like Huntington's disease or sickle cell disease. I mean, those are diseases that's too bad if you inherited that. If somebody says, well, malocclusion, it's all genetic, and there's still some people hanging on to that. And it's just, I don't know, it'd almost be like somebody is so resistant to using a laptop that they want to use their grandmother's computer, their typewriter. It is so since the Human Genome Project, like 25 years ago, 26 years ago, anyone who understands how genes and environments they do a dance together, they always have, they would never say malocclusion is like eye color. It is just there, certain genes match up and you're going to have malocclusion.
um,
No, you're not.
so
You're
there's
just
not
not.
that typical, like, Mendelian thing or whatever. So eye color is a different way that it's represented versus malocclusion. So I know a lot of people use the word epigenetics, like above the level of the gene. Can you talk about what epigenetics means?
Yeah, epi just means above. You have a genome, you have an epigenome, and that is the genes that have switches. A lot of genes, and even eye color, Nicole, they're finding out so much more. There could be something going on, maybe during the first part of the first trimester, depending on the mom's temperature or the delivery of oxygen via the placenta, that could maybe all of a sudden little b doesn't necessarily just make blue eyes. We're learning more and more. But we know for certain, I wouldn't even say Oh, well, it's got to be several different genes on several different chromosomes, not only interacting with one another, but in concert, dealing with the maternal environment in utero, and then also in concert with the external environment of during pregnancy and then after pregnancy. What's going on? And is the child born prematurely? Are they in a neonatal intensive care unit that has 24/7 bright lights going on? Well, that child never can develop circadian rhythm. They call circadian clocks in every single cell that we have. So there's just so much. This is a wild west. There's so much that's not fully understood about this, but we know for certain if a child did not have a perfectly wide forward jaw with well-aligned teeth when they come in, an ability to chew pretty much all adult foods by the time certainly they were 12 to 14 months of age, baby-led weaning, they wouldn't survive. And there's some cultural things about hunter gatherers, which we all were till about maybe 12,000 years ago when we discovered agriculture, and then there was a transition. But hunter gatherer tribes, and there was less than 1 million people on the earth. Now there's how many? 7, approaching 8 billion or whatever it is. And they were all in Africa until about 70,000 years ago. Our genus, our species, Homo sapiens, they would move around every 6 to 10 weeks. If a child couldn't eat everything that everybody was eating, they got left behind. Sometimes they call it infanticide. It would forget the tribe. It wouldn't allow them to migrate with harvests, ripening apples, buffalo, following buffalo. People migrated constantly following food sources. And babies had to be robust and ready to move on usually by the time they're a year old. That's where the baby-led weaning concept, Joe Rapley, that's where she came up with it. She's an anthropologist.
Yeah. Well, it's interesting, like now, what is it? Like 99% of kids have malocclusion. Why is that? And is that preventable or just partially reversible? Like, how can we undo what these sort of epigenetic changes that have
Well,
occurred?
you brought up preventable and reversible, and you use that very fluently, like it just rolled off your tongue. And I helped develop with John Mew and his son. This was maybe 15 years ago when I took John Mew's course. And we developed this concept that if something is classified as a chronic and non-communicable disease or a disease of civilization, a disease of modernity, it would follow a pattern. It is first preventable if it's identified and the environment is conducive to not allowing a disease expression, like type 2 diabetes. Okay. If that suite of genes, we don't say one gene, one disease, very not for type 2 diabetes, or malocclusion, if we identify somebody at risk for whatever, how you do it with a genotyping or a family history, but you don't subject that child to a disease producing environment. In the case of type 2 diabetes, that means poor diet, minimal activity. That kid is going to lose the ability to regulate glucose. Okay. That's a disease phenotype. But the genotype, the suite of genes that might produce type 2 diabetes, if you put that child from the beginning in a healthy and ancestral type environment, that kid will go from birth to death never expressing high blood sugar. That's hypothetically, that's how a disease of civilization works. Well, if you put malocclusion into that category, that means that kid is genetically predisposed. Why? Because he's a human and they're predisposed to it because they're no longer in the 300,000 years of an ancestral feeding environment. That means nursing on demand for at least 6 months, if not longer, maybe 10 to 12 months, sometimes longer, and some what we call extant existing Aboriginal cultures that still there's not very many left in the Amazon and parts of Africa. The Khoisan are what we all evolved from. But if a human baby is raised by hunter-gatherers on a hunter-gatherer diet in a hunter-gatherer environment, they're not going to develop malocclusion. Malocclusion, when it happens in a single generation, you can have people that, and again, I have Ethiopian patients, and the mom, she says, I was raised in the villages. She has perfect teeth. I was not raised in the city. I was raised in the villages, and I nursed till I was 3 years old. And one time her niece came over, and this child, she was like 14, and she had wisdom tooth to wisdom tooth, perfect teeth. And her mom looked at me, and I said it with her. She was raised in the villages. That's the way it was. And guess what, Nicole? She had a grade 4 plus tongue tie. Okay. So it's counterintuitive, but there's at least some, and I've heard this said by other people, is that it's the feeding environment that can turn a tethered tongue, a grade 3 or 4, into a disease because of the way they're fed. Now, I'm basing that on 2 or 3 Ethiopian kids that had tongue ties but didn't have any malocclusion. So, but they were nursed for 4 years, and so I don't know. They were obviously able to latch. Not every kid with a tongue tie has disability to latch or has pain or.
Yeah, like you said, though,
But
the way they were fed, like
yeah,
Bar always says, mastication, or Diane mastication builds and forms bone. So that chewing pressure and the mechanics of chewing maybe overrides whatever compensations the tongue tie might cause.
yeah,
It's
that's
really
it.
interesting.
Absolutely. And when in doubt, and I leave it to a qualified professional, I don't diagnose what I don't treat, and I don't perform frenectomies. I have Milt Gavelis, who was trained by Saru Sagi. He's in my backyard, literally. He comes to my office sometimes, but he's, you know what? And he works with about 70 greater Chicagoland myofunctional therapists who all understand how to grade a tethered tissue, and then together with Dr. Gavelis or with Larry Kotlow or Kurt Coleman, we've got several people in Chicago that are doing this, and they perform, and they have all kinds of metrics they use. They just don't automatically do surgery on everybody, but there's criteria.
And like as a myofunctional therapist, there's such detailed ways that we evaluate for tongue and lip tie, because we're not just looking at the location or the placement of the tissues, but we're looking at how it affects functioning. So oral rest posture and chewing and swallowing. So I've had other practitioners. I recently had an MD say, "Oh, just tell me, how do I assess tongue tie?" And I'm like, that's not like a simple thing. We use a variety of rating scales. It's all based around function. It's a detailed ways, and also looking at compensation. So yeah, don't treat what you, or don't assess what you don't treat, and vice versa.
Something really interesting happened. We vacation every year near the town where I grew up on Lake Michigan, and it's about 3 hours from Chicago. And we rent the same cottage every year. And my kids have these friends over 20 years they grew up with. Well, one of them came to our cottage to say hi and show us her new baby and little Eloise. And it turns out this woman, she is a very famous person. She is the prima ballerina for the Royal Copenhagen Ballet in Denmark. And she came over with her baby, and oh, look at Eloise. And I said, "So are you nursing?" She goes, "Yeah, but it's miserable." And I said, "Really?" And she lives in Denmark, right? So I looked, grade 3 plus tongue tie, grade 3 plus lip tie. She's wearing a nipple shield. And I said, "Didn't anybody tell you about this when it was born in Denmark?" I connected her. Thank Mark Moeller and Samantha Weaver both connected me with people in Copenhagen. They got her assessed, And she ended up going to London, working with Katrina Rogers
Yeah,
and this gentleman who I don't recall his name, but he performed the surgery on her. And oh, she's making a video that's going to be shown all over Denmark of
that's
how
so
this happened. Isn't that amazing?
when you know
I mean, it
something,
was just
you
like
see it.
serendipitous.
That's the thing, spreading the message because mothers shouldn't be suffering and in pain, and that's not how it should be. And we need exactly what we're doing now, spreading this knowledge and information so we can help more families. Wow, that's such a
Yeah.
great story. I want to see that video.
Isn't it cool? Yeah, well, I can send you the prelim, but she's going to have it professionally done.
That'll be neat.
So
So,
yeah.
well, okay, we just talked about causes of malocclusion, epigenetic changes, our changes in our diet, our environment, decreased
Mhm.
breastfeeding, which we know is a natural catalyst for normal oral facial growth and development. So, let's talk about your treating children. You said to age 2, but average age 3 to 5 years old. And malocclusion, you said hypoplastic jaws will never
Yeah.
self-correct. So what are some red flags that you see in a young child that parents should be aware of and other practitioners that child needs early orthodontic, dental, skeletal, craniofacial intervention?
Well, for one thing, and again, we're exploring, and I almost had an orthodontic resident at one of the Boston ortho residencies to do this for her research, is that looking at mid-gestational ultrasounds of children who had retrognathic mandibles and using a validated metric called the inferior facial angle, which OB/GYN radiologists look at to look for syndrome. And he said some of these kids that don't have syndromes, but their jaws are still far back, that does it go away? Let's form the hypothesis. It doesn't go away. It persists after birth and it will become more complex. That was the research question. And she was all set to go to IRB with this, and then her director ended up leaving the program, and she had to scramble and get a new project. So we still have the protocol, and I'm going to be interviewed by people who have 2 NIH grants that are really interested in this hypothesis. So it could show up before birth, but let's just say certainly by 2.5 years old, when a child usually has all 20 of their baby teeth, certainly by 3, between 2.5 and 3, that chin will not come forward. That deep, narrow palate is not going to get shallow. That V-shaped arch is not going to become U-shaped. The lack of spacing between the front teeth is not, or crowding, that is not going to self-resolve. It won't. And that's been understood. And what I really, when I teach, there's something called a distal step molar relationship. You know what that is, but most people don't. And I'm teaching this to physicians that when the lower jaw in a 3-year-old is retrognathic relative to the cranial base, you will see a relationship called a distal step. It's a class 2 molar relationship, and it's one of the only molar relationships. There's also mesial step or flush terminal plane, we call those. The distal step will always, 100% of the time, develop into a full skeletal class 2 malocclusion
Mm.
if measures are not taken to help those jaws develop to their full transverse potential and then start to guide that lower jaw forward. You don't solve it. You don't completely cure it. There's things that can be done now with guides and getting myofunctional therapy. And Dr. McNamara at Michigan talked about spontaneous correction of class 2. You overcorrect the narrow maxilla and you have the child bite forward so that the lower jaw fits better in the forward position. We have children bite on a micro brush, the back of it, and hold it forward and talk with their mouth closed like a ventriloquist. That's a myofunctional exercise that I pretty much learned from you guys. And we developed this thing with the stick. And then we get them into myofunctional therapy. Eventually, that will try to get things to start growing forward, but then we can add a dental-facial orthopedic appliance. I use all kinds of different functional appliances to help children help their jaws come forward, and not just the lower jaw. When a lower jaw is too far back, what I tell people is if the lower jaw is a mile back and the upper jaw is a half mile back, nobody recognizes that upper jaw also needs to be brought forward. So more often than not, if we've got a lower jaw that's too narrow, that means the upper jaw is too narrow, right? And Mariana Evans teaches this. If you see anterior crowding on the lower jaw in the incisors, 100% that is a proxy for maxillary transverse deficiency, okay? Because the lower jaw is not able to grow right. And Mariana also teaches, even if this child is not displaying airway issues, it's a good idea to develop those arches so that the permanent teeth will grow into what she calls juicy cancellous bone, alveolar bone, and be more resistant to age-related periodontal disease when they're older. Much less, there may be sleep and breathing issues that aren't perceptible yet. They're not gross, but you know what? Get a hold of it. The malocclusion is not going to self-correct. So, but you don't promise really anything. That often this will coincide with improved neurological and neurobehavioral development, improved hearing when there's conductive hearing loss, improved cardiovascular health if there's high blood pressure in a child, quality of life. There's so many papers that talk about maxillary expansion conferring better quality of life. Well, that means the kid was transverse deficient if they needed or it was indicated to expand them, right? So these are all things that just orthodontists don't want to talk about it. I was just at a meeting in Florida, Marco Island, you heard about it, the Academy of Pediatric Dentistry and the Academy of Orthodontics. The head of orthodontics, Dr. Greeley from Seattle, Washington, got up in front of everybody and said mode of respiration has nothing or very little to do with how the face is going to grow and the jaws. And I got up and I said, sir, have you heard of adenoid face? And I went and sat down. I didn't think he'd debate me. And he tried to defend it, like maybe thinking that I didn't know what you know what? I was walking away and I sat down in my chair and he was still up there trying to defend it. I was flabbergasted, and so were other people, but nobody said anything.
Oh, that's
anyway.
Horrible. It's the wrong misinformation. That's just horrible for a group of people that should be the most impacted and could have some of the most impacts off of knowing this information to say that. So, okay, question about class 2 malocclusion. So is that always consistent with a narrow palate?
Yes, you will always, I'm sorry, never say always, but you know what? If you see a jaw that's protruded in the maxilla and it's the lower jaw is not growing right, it's not wide enough, always you will have to widen the upper jaw to get the lower jaw to fit into the properly positioned mandible. When it comes forward, they're not going to coordinate if you don't widen that upper jaw first. McNamara, again, he's one of my heroes, is that he shows literature from 100 years ago in the German literature showing a shoe and a foot, the upper jaw being a proxy for a shoe that's too small, and the mandible protruded being a foot that the toe can't get to the end of the shoe. You have to widen that shoe first before the lower jaw can come forward. So yes, you will see them always together. And it's the same thing. When you see a protruded mandible, you're going to suspect the maxilla is not forward enough also.
Yeah.
But there might not be an underbite, class 3.
And that's how I was as a kid. So I got a neck gear and never expansion. So we don't want head gears or neck gears. Can you talk about what we do want to treat when we see those either narrow palates or class 2? And I also want you to talk about crossbite or skeletal versus dental crossbite. So there I go, asking 10 million questions in one question. But can you talk about?
I'm only going to talk about maxillary transverse insufficiency. Okay. All right. Maxillary, you do not need a posterior dental crossbite. If there's a dental crossbite, There's a skeletal problem. They're all skeletal malocclusions, okay? And sometimes they manifest as a dental posterior unilateral bilateral crossbite, but you don't need that crossbite because what often will happen is you will get compensation. Is that the teeth, the upper teeth will tip out or the lower teeth will tip in, and there's no crossbite. So, oh, I don't need to do anything. Watch a video by Sean Carlson, who's a San Francisco, Harvard trained orthodontist, and he discusses a study that was done at Boston University with Leslie Will and Mila Motro. It's an amazing study that shows you do not need a dental crossbite to diagnose skeletal transverse deficiency in the maxilla. Okay, so end of story. You don't
Yeah.
need to talk about it anymore.
I had a teen patient who had major signs of sleep disordered breathing, really narrow palate, and the orthodontist didn't want to expand because he said she doesn't have a crossbite. And I was like, oh my gosh, like, what do I say? I'm the myofunctional therapist. I'm not the orthodontist. But I just asked him, I said, have you ever heard of a skeletal crossbite? And he said, no. And that was the end of the
And he
story.
hasn't. It's not his fault.
Yeah,
And
and
I just say it's not their fault, Nicole.
yeah, there
It's
you
their
go. See, you're
curriculum. It's
understanding
their
that
curriculum.
it's the curriculum.
Don't
Yeah.
judge them. Yep, it's not their fault.
Don't judge, don't get angry, but parents did end up getting some other opinions who did say the child needs expansion, so they just, went somewhere else. They were in that phase of figuring out what to do for her. But
Yeah.
it is true that it's many people are not aware if there is no dental crossbite, it doesn't mean there's no problem. It doesn't mean there's not transverse maxillary deficiency. So I want to ask you, um, about myofunctional therapy. How did you learn about myofunctional therapy? What it is? What are your thoughts?
It was a mistake. It was serendipitous.
How you learned about it?
Well, listen, this is an amazing story. And believe me, I did used to think it was voodoo. I didn't understand it and I was critical of it. And one day I was blessed by a patient who had left my practice because they had moved. And I had this child worked up. There was maybe a crossbite, but certainly this kid needed expansion in the upper and lower. Well, 2 years later, they moved back to Chicago into my practice. And oh, you had phase one orthodontics done. No, that's why we came back here. You said we needed it 2 years ago. And I said, but oh my gosh, I've got pictures and I showed, I didn't, I don't know if I had x-rays, but because I didn't have a cone beam then but whatever. And I said, this looks beautiful. I don't know if the indications are there anymore. And you didn't have orthodontics? And she said, no, but we did have something called myofunctional therapy. And the woman, Carol Mayer, her name was, she was a speech pathologist. And it turns out these people didn't move to another state. They moved to the suburbs and they didn't want to come into the city or they got different insurance, whatever. And so I called Carol Mayer. What is this what did you do? And she came to my office and gave us a little talk. And then she started working in my practice, just seeing patients once a week or a couple times a month. And then she is a teacher. So Kristen Miller, who's a very well-known myofunctional therapist in Chicago, speech pathologist, did her internship with Carol Mayer in my office. Well, then Kristen started working with me. And the rest is history. Kristen taught me so much. She bought me a book on SLP and how, infantile swallowing won't mature into lateralization unless you get the pacifier and thumb out and non-nutritive, all that. So that started the journey for me.
Wow.
And now I discovered the work of Dr. Rogers in the 1920s. And I am so grateful for you guys. It's helped my results achieve faster, more efficiently, and more stable, less resistant to relapse.
Do you think all cases of malocclusion have an underlying soft tissue dysfunction?
Unequivocally, if there's malocclusion, there's myofunctional disorder. I'm of the mind, and Linda D'Onofrio was the first one to introduce me to that concept. And I feel it's a robustly supported hypothesis. I mean, the law of gravity, that's a hypothesis. I think there's a lot of evidence that it's a law. I mean, evolution by natural selection. Are you kidding me? There's more evidence for that than there is gravity, maybe.
So do you
To me,
think,
it's unequivocal.
okay,
Yeah,
do you think every orthodontic case needs myofunctional therapy?
absolutely, unequivocally. I mean, if you want to prevent relapse and a kid that's being treated to later is no longer a kid, you unwind it, remove the restrictions, expand, protract, don't retract, don't extract. You do all these things, you're going to have a more stable result if there's myofunctional therapy as an adjunct. For me, if I've got a kid who doesn't have 20 teeth, I mean, they're a year and a half old, two, don't have 20 teeth yet, I will put with the myofunctional therapist and recommend a myomunchie or some other form of device. There's other ones coming. I happen to like the munchie. And full disclosure, they're funding research, a big project that we're going to be running here. And they're going to publish the results, whether they're good results or bad. That was one of the conditions, of course. And no, there's lots you can do for kids before they have 20 teeth, or kids who have 20 teeth, but the parents, for whatever reason, aren't ready. There's obstacles, distance, finances, maybe mom's for it, but dad, I didn't get braces till I was 13, or Boyd's not even an orthodontist. I want a real orthodontist. I mean, there can be all kinds of things. The pediatrician's poo-pooing it. The ENTs poo-poo. You have to just try to treat as many kids as the parents that want it. There's enough people out there where there's not obstacles.
Yeah.
Treat them. You'll see it. It'll grow.
Well, what
It'll
do you
grow.
feel like parents or practitioners, like myofunctional therapists, what should they do if they have concerns about like a child's occlusion or sleep or airway functioning or even like a tongue tie, but the pediatrician or dentist or orthodontist is telling them to wait or not listen to their concerns or wait till they have all their adult teeth before we're going to treat? Or what advice do you have for parents or practitioners who are feeling this way?
Well, when I'm talking to parents, or if I'm talking to practitioners, you know what? With the parents, and again, most encounters of pediatric healthcare professionals are with the female adult caregiver, the mom, the aunt, the grandma, the nanny, the big sister. All right. And I do say, quite frankly, and I grew up but raised by a single mom. I have two adult, mature, great citizen daughters. My wife is very forthright in building instinct in our daughters and trusting her own instinct. And I just say, you know what? If your pediatrician is telling you it's nonsense, what does your instinct tell you? I don't try to trash the pediatrician. Like I said, I haven't always been there, and I'll tell that to hopefully they'll listen. Maybe I'll send a radiology report. Maybe if they won't listen to me, they might listen to the radiologist, who often, and I work with two radiologists, Francisco Arasso and Nick Schuff, at Beam Readers, and they have both learned this early childhood, early airway analysis, measuring the adenoids free airway space with the Linder Aronson metric. And they will write on the report on this Panorex, those permanent canines will never have enough room to erupt. Well, what's that a proxy for, Nicole? Lack of tongue space now. Of course, at 12, that canine isn't going to erupt ideally. But that means that 4-year-old doesn't have room for their tongue now. If there's not room, predictably, for the canines to fit when they're older, that means there's lack of tongue space now. And that's what I tell parents. So you give them information and
Yeah.
let them figure it out.
It's great advice. Yeah. Give them the information, give them the facts, the data, the reports, and tell the parent, what is your gut? What is your instinct? Because I think sometimes parents might get dissuaded thinking, oh, that's an MD. They're above me. They know better than I do. But really trusting your own gut and your own instinct is usually right on. If you sense something's not right with your child, or you're worried, you're concerned, I think go with your gut, tell the parent, what is your instinct telling you? I like that advice. Why do you feel certain practitioners, like certain dentists or orthodontists, maybe ENTs or pediatricians, are resistant to early intervention or even just recognizing such issues? Do you just feel like it's lack of education?
Yes, in the curriculum. And let's go right to the curriculum.
Okay.
The pre-doctoral curriculum, dental school curriculum. There's a paper published in 2017. This is just relative to restorative needs, okay? The demand to get cavities filled. The Academy of Pediatric Dentistry, authored by the CEO and his son of the Academy of Pediatric Dentistry, John Rutkowskis, and his son were co-authors on this paper. But it said pre-doctoral students are inadequately prepared to deal with just the restorative demands, and that they might actually be doing harm because of pre-doctoral education. This is before Airway enters into it. Now, also, pediatric behavior guidance. Okay, I had to demonstrate hundreds of hours of clinical opportunities of managing anxiety in children and their parents relative to restorative and oral surgery needs. Doing orthodontics is a cakewalk. This isn't, and you understand pediatric child development. I had to take lots of courses in that. And it's like you can help parents understand this is in your child's best interest, best long-term health, and not only lifespan, how long they're going to live, but something called health span, how long they will stay healthy into older age, sleeping and breathing, and self-control. A paper just came out. Children who lack impulse control and grow into adults who lack impulse control as long. So you can back extrapolate that. When you help a child sleep and breathe better, they're going to have better impulse control. Okay. And there's something called the Dunedin study done on 1,037 babies born in the same hospital in 1973-74. Over 1,000 of them are still being followed. Those children who demonstrated, you've heard of the marshmallow test, but there's validated metrics for impulse control. Children, according to the Dunedin cohort, that could demonstrate good impulse control before the age of 12, they will live longer, and into their 30s and 40s, they will manage wealth better. They will look 10 years younger than kids who didn't manage impulse control well. They will have less criminal behavior and less chronic disease, less addictive behaviors. Read it, the Dunedin study, impulse control. Just Google it. It's amazing. And now this new study, British Journal of Psychiatry, adults with attention deficit disorder, you know what? They're not going to have as long a lifespan as they would if, as children, they were able to overcome it without just doing drugs, Ritalin and things like that. It's amazing. It just came out maybe a month ago.
Wow, that's
Isn't that
amazing.
amazing?
Perhaps
Yeah.
we should all do the marshmallow test as a screening for all of our patients and then check Airway.
Yeah.
Like if you can,
Yeah.
great, but without taking the marshmallow. But wow, okay, so just as we wrap up, where do you see the field of dentistry and orthodontics going over the next 5 to 10 years and maybe longer? How do we make these Airway type changes? You said like just getting into the curriculum. What do you see and what are your hopes?
Well, largely because of the efforts of Jerry Simmons and Steve Carstensen at the American Dental Association. This is now seen, airway health is seen as much a component of what defines oral health as healthy gums and caries-free teeth. So I just think it's on a fast track. It's not happening as fast as we'd like. Hopefully, all of our life's missions will outlive us, and we need to keep pushing. Also, Candy and Brad Sparks, the Child's Airway First Foundation, is an amazing organization. We just met, all of us, in Seattle last weekend, and it was an amazing, and it's something that I really think is going to go to the next level, largely because of the people that were in that room. Oh my gosh, you would not believe the personalities that were there. There was epidemiologists. There was a gentleman, Finnegan, John Finnegan, he's a former dean of public health at the University of Minnesota. Stanley Liu was there. He's now at Nova, but studied with 𝐃𝐈𝐒𝐂𝐋𝐀, and there's going to be a consensus statement made, and they're raising all kinds of money to fund a validation study for the 𝐃𝐈𝐒𝐂𝐋𝐀 that Jerry, I'm on his task force for screening. So I'm really optimistic because of things that are happening behind closed doors, and they're getting out in the open. And largely, what you're doing here, Nicole, with this, and Mike DeLuke with the Doc podcast is really opening up a lot of eyes. So I'm very optimistic.
That's so great. Yeah, Mike DeLuke and I, we do every other month a conversation, Airway conversations together, where we go back and forth talking about just chatting Airway stuff and questions we have or different things that come up. So we just started doing that recently also, which is really fun. And the 𝐃𝐈𝐒𝐂𝐋𝐀 is part of the Children's Airway Screener Task Force. I'm on that team with you as well, developing that universal screening tool that all dentists will use to screen children for sleep disorder breathing. So I feel like change takes time, and especially when we need research and evidence to back things up, but this will happen. And all the teaching that you do and all the endless lectures that you do, and you're always going places to conferences, is helping to educate so many people. And the fact that you look deeper as to where did this all begin? What is the root cause of this? And how do we treat beyond treating symptoms, but treating the underlying cause is so important. And you're just so fascinating to learn from. I really just appreciate all your time in all that you do and helping to educate not only practitioners, but also parents and families. So thank you so much, Dr. Boyd, for being here. I really had a great time with you.
Well, my parting word is pediatric behavior guidance needs to become part of the pre-doctoral dental school curriculum and the orthodontic curriculum. Orthodontists don't have 1 second of requirement to learn how to anticipate and manage anxiety in little kids, which implies they shouldn't be treating them. That is a word that starts with bull, has an S in the middle, and it's not bullseye. Okay, so that's how I'd like to finish, and thanks for the opportunity, Nicole.
Amen to that, for sure. I mean, this should just be, like you said, standard curriculum. We need to identify and treat these children early to make the most change, the most impactful change. And this really has got to get to the graduate programs. I mean, that's where it sounds like that's the best place to get this information out before it's too late and people are treating symptoms later and adults are ignoring it. So yeah, keep up all the work you do. Thank you so much for everything, Dr. Boyd. I really appreciate it.
Okay, say hi to your husband.
I will. Take care.
Talk to you later. Okay.
Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.